The tip lesion refers to when you have, this doesn't even really look like an area of sclerosis at all, but it's part of the sclerotic, the FSGS rubric. Here we have the glomerulus. Here's the vascular pole. Here's where the Bowman's capsule opens up into the proximal tubule. Okay. When you have an area of, let's just call it abnormality, this doesn't look like sclerosis, but an abnormality at the glomerular tip where it juxtaposes with the proximal tubule, we call this a tip FSGS. Okay, this is not really an area of sclerosis. Sometimes it can be. Often there is a little bit of what we call a synechia, a kind of a tether, an area of sclerosis that is tethering this tip lesion to the epithelium, so that adhesion can be there, or some people would call it synechia. Sometimes, again, you'll see, just as here, this prolapse of the glomerular tuft into the afferent, into the proximal tubule. And then what you're seeing often is, once again, these angry or activated, let's call podocytes, increased cell number, foamy cytoplasm, and that's what the giveaway is, that this is a tip lesion. Okay. The cellular variant of FSGS is the most rare form of FSGS. This is bizarre. You would say this is endocapillary hypocellularity, or you might call it mesangial, but this really, to me, looks like endocapillary hypocellularity. Okay. And you will then say, well, this is lupus, right? Or this is infection-associated GN. Well, how do I say that this is not these? Well, when I do immunofluorescence, I see nothing. All those other proliferative glomerulonephritides are going to have immune complexes, complement. So if you see a cellular glomerulonephritis, but the immunofluorescence is negative, and they're presenting with nephrotic syndrome, you call it. This is cellular variant FSGS. Okay. You can have this reactive podocyte as well in this condition. So these podocytes are sitting on the outside. They have kind of somewhat enlarged nuclei. I don't see the foamy appearance on these. All right. Perihilar FSGS is one clue that you're dealing with a secondary form of FSGS. Okay, remember I told you you're often having to make the diagnostic distinction between primary and secondary, not just because you want a tidy thing to write in your note, but because it drives management, right? You don't treat secondary forms of FSGS in general with immunosuppression. So one giveaway or suggestion that this is a secondary form of FSGS if the area of sclerosis is in the vascular pole. Okay, that would be the hilum that we're referring to, the vascular pole where the afferent and efferent arteriole are coming into the glomerulus. Okay, you may see glomerulomegaly as another clue of this form of perihilar FSGS. We have some recent patients who had severe preeclampsia. Their biopsy shows perihilar FSGS. Okay, but remember again, it's often the case you don't slice the glomerulus right at the vascular pole. So just because you don't see perihilar FSGS doesn't mean you're not dealing with a secondary form of FSGS. Okay. Some of these patients are nephrotic, some of them are not. Again, microhematuria is quite common to see. Hypertension is more consistent than with with minimal change disease. And these patients will often have varying degrees of CKD or impaired GFR. Okay. How do we discriminate the primary and secondary forms of FSGS? We alluded to some of this. I'll highlight an electron microscopy finding as well. The primary form of FSGS generally clinically presents with explosive onset of nephrotic syndrome. So I gained 30 pounds in the last 2 months. That would be a clue that this is not a secondary form of FSGS. This is primary. Okay. When you have hypoalbuminemia, also kind of the same picture. Okay. You're on EM going to have, usually, this is not 100%, more diffuse foot process effacement on EM. Okay, so 80% foot process effacement, If you see that patchy foot process effacement, you'll be calling into question whether this is primary FSGS. You can absolutely still have patchy foot process effacement in a form of primary FSGS that responded to steroids. How did I know it was primary? Well, I gave steroids anyway, even though they had 20% foot process effacement. I gave them steroids anyway. They got better. Proof positive. You had primary FSGS. Okay. The secondary forms generally have varying degrees of glomerular enlargement, the perihilar distribution, and these patients are often, people who have creatinines of 2, albumins that are normal, 2.5 grams of proteinuria. That's a classic presentation of somebody who we would call secondary FSGS. Okay, mostly like CKD patients in your, like a hypertensive nephrosclerosis patient. All right, collapsing variants typically has more severe proteinuria. They often have more rapid progression. And then certainly we have the genetic and racial predilection, which we've talked about. TIP variant really looks more like a minimal change patient, both in terms of how it presents and its treatment responsiveness. Okay, it's good to have TIP variant, although that itself is not reassuring. I've had TIP variants who have progressed to ESRD. The prognosis for the primary form is generally good. Okay, this is not the secondary FSGS. With a focus on primary FSGS, the primary is good if you're subnephrotic. That's why we don't treat you unless you're nephrotic. Okay, you can challenge me and say, well, what about somebody who has 2.7 grams of proteinuria? Are you going to treat those patients or not? So there's diminishing returns as you develop these, prominent but still subnephrotic range proteinuria. There's diminishing returns of steroids in those patients. So, would I potentially treat somebody who has 2.7 grams of proteinuria if otherwise they had no side effects? Maybe. But generally speaking, I would be leveraging all my antiproteinuric interventions. And if I plateau out at 2.7, I might say, okay, well, maybe let's try steroids and see if we can get it a little lower. Okay. But the return on investment for somebody who's got some nephrotic proteinuria is less because in general, those people are going to do well. Nobody has, however, published a specific case series of what happens to the patients with 2 to 3 grams of proteinuria. Actually, there is a paper that came out of the a study that we're a participating site on that suggests that maybe these patients with 2.5 grams of proteinuria should be considered for treatment. Okay. All right. So the strongest prognosticators is treatment response. Here's some numbers that you can digest if you want to present that to your patient. What is the renal survival rates when you have complete or partial remissions? I'll let you read about that, but it's intuitive. It's unlikely to have patients that have spontaneous remissions. Complete remissions are, remember, in complete remissions, that's the norm in minimal change disease. But you can see here that complete remissions in FSGS is not the normal. Many patients are just achieving partial remission in this condition. Some of that has to do with because we've probably have some cases of adaptive FSGS that have included in some of these estimations of remission rates. It takes longer to remit. Okay, so generally that informs treatment. We're generally committing to 3 to 4 months of high dose steroids. Remember, in minimal change disease, we're looking at about 8 weeks of treatment. In these conditions, you're looking at in FSGS, you're committing to about 12 to 16 weeks, 3 to 4 months of high dose steroids, because it takes a while for these patients to remit. It's quicker again in pediatric patients, and so they don't typically use 3 to 4 months in the pediatric population before calling somebody steroid resistant. Here's some predictors of worse prognosis. Cellular variant and collapsing variants do have worse prognosis. Okay. Relapses are frequent. These clinical patterns that we previously introduced are once again rearing their faces here in the conversation on FSGS. Steroid responsive, steroid dependent, steroid resistant. Notice here that the frequent relapsing has fallen out. Why? Because I just don't have as much time to have 3 relapses in a year if I'm committing to 3 to 4 months of prednisone therapy, right? So steroid responsive disease, here's some take-home messages that you can use that I use all the time to educate my patients. About 50% of patients with FSGS, primary FSGS, will be steroid responsive, okay? Of those who don't respond, about 50% will be calcineurin inhibitor responsive. So if you do the math, that leaves 25% of primary FSGS that doesn't respond to either steroids or calcineurin inhibitors. Those patients generally do poorly. Okay, we have a patient at Parkland, Mr. Barnes. That's the spiel I gave him. Even though, is he still in the hospital?
He got moved over to the overflow team. I don't think he's in the hospital anymore.
Okay, but he's putting all his money in. Oh, rituximab's going to save me, and I'm trying to prepare him for the fact that it's probably not going to work, right? For a couple of reasons. Remember, I told you rituximab is probably better, a little better for getting someone or keeping someone in remission, not so good in getting them into remission, right? So he's nephrotic, he's going to pee out that rituximab. And then also he's in this steroid refractory now. We haven't proven he's calcineurin inhibitor refractory because his GFR is too bad to try that, right? So but still, I think he's gonna not really do that well. Okay, so again, 50% response rate, and then of the remaining non-responders, 50% of those respond to calcineurin inhibitors. Okay, and once again, if you respond to steroids, you're going to respond to calcineurin inhibitors. So if I find somebody who didn't respond to calcineurin inhibitors after responding to steroids, I'm questioning whether the dose is right or the patient's taking the med. Steroid-dependent disease are the patients who, we've already defined that for minimal change disease. I'll let you sort of just, extrapolate that to the FSGS. The resistant patient is the patient who doesn't respond to a good 12 to 16 weeks. That's 3 to 4 months of high-dose steroids. That's hard. Just think of what you're asking your patient. Be 60 of prednisone for 3 to 4 months. Oh, they all get Cushingoid, right? So this is really, hard for your patients. And I've had patients who got new onset diabetes. I've caused that. So this is not an easy treatment, okay? I've used 50% to simplify the responders versus the resistant patient, but you can use 40 or 60%. All right, so treatment, once again, you treat only the nephrotic patients. There's some debate about whether you should treat at 2.5 grams, but you first do all your anti-proteinuric interventions first before you commit to the immunosuppression, right? And your goal is to get them subnephrotic, and you should call that a win, okay? Because these medicines have toxicities. So going for the goal of complete remission on your patients is going to be, first and foremost, the complete remission rates are uncommon. And so you should be really accepting a win when you get subnephrotic, okay? The treatments are going to involve prednisone. You can see some of the same patterns of duration of therapy that I've given you for the minimal change patient, but you do push out to 12 weeks to 16 weeks before you start calling it steroid resistant. You can consider treating that first relapse with prednisone again. I find that patients, after they've gone through 3 months of steroids, are pretty reluctant to do it again. Okay. And then you can certainly consider calcineurin inhibitors for patients who have relative or absolute contraindication to steroids as a first-line treatment. Okay. So if you do not have a lot of interstitial fibrosis or severe CKD, as like Mr. Barnes, then calcineurin inhibitors can be tried. Remember, once again, you're committing to about 24 months okay, of treatment. And I've given you this number already, 50% of the non-responders to steroids are responding to calcineurin inhibitors, okay? Often, again, the GFR is a barrier, right, to leveraging the calcineurin inhibitors. If you get out to 3 to 4 months, then you don't need to keep hammering. Once I get to 4 months and I'm getting no bang for my buck, none at all, I'm calling them calcineurin resistant as well. Trying to keep going to 6 months or more with a calcineurin inhibitor, treating kidney disease with a nephrotoxin. I really sort of at that point, at 4 months, 3 to 4 months, I'm really considering at that point peeling off. Rituximab is a treatment option. Once again, maybe it's more effective with maintaining remission rather than inducing remission. Mycophenolate data is very limited. Cyclophosphamide data also limited. There's a drug out there, Acthar. I've never prescribed Acthar. It's keep in mind that it's somewhere around $600,000 for 6 months of Acthar. So you get nice dinners over Acthar, but really, think about it when you want to use it. This drug was approved before normal standards of FDA approval, were established. There was no randomized controlled trial with Acthar, even though now it's a approved drug for nephrotic syndrome. It was approved back in the early days of the FDA before there was any requirement for rigorous data. We'll finish the rest later.
Like how ACTH, how that works differently than just giving steroids?
Yeah, it was approved for nephrotic syndrome because patients who got ACTH, some patients who got ACTH got better, and that was sufficient for FDA to say, we approve this drug. And probably a lot of that, those original responses were because they were having their adrenal gland produce more glucocorticoid. That being said, there's a data that suggests, particularly in the membranous literature, that suggests that ACTH may have some novel effects on podocyte biology through a different receptor, not through glucocorticoid receptors, but through melanocortin receptors on the podocyte. I don't buy it.